No. We said it's gonna be yeah, it's okay. Yeah. What is Sarah? This was good. Yeah. You see that? You're not cheap. You're
Okay, good afternoon, everyone. Yeah. Hello, everyone. Welcome to today's class. Today's class, we will talk about a very, very important topic, how to critique pharmacoepidemiology studies. So in today's class, we will start with a case study. And then we will specifically talk about the checklist that many of you may have already read it through the reference book. We will talk about some of the important points in the checklist. And during the second half of class, you will have some time to work with your group mates, group members for the checklist. Okay? Okay, so let me start with a drug. Many of you may heard about this drug. It's drug. I'm not good at pronouncing the drug name. Let me try rosiglitazone. Okay, rosiglitazone. You know, this is a drug for diabetes 2 patients. This is a drug that can lower the patient's blood glucose, blood sugar in your body. The drug is marketed by a famous company called GSK in 1999 and has been approved by both the US FDA for treating the type 2 diabetes as well as the EMA in Europe for the type 2 diabetes indication. They have found out the efficacy of the drug, obviously, in treating the diabetes patients in clinical trials. And as we have all learned about RCT usually has a relatively smaller sample size, maybe like 100, 200, less than 1,000. So the RCT is not powered to detect any of the adverse events or the risk associated, cardiovascular risk associated with this drug. Like I said, the drug has been approved by both the regulatory body in the US and in Europe for the controlling the blood sugar in the diabetes patients. And I want to bring your attention to this high impacting, high quality publication in one of the famous, actually the top journal, NEJM, the New England Journal of Medicine, by a doctor called Steven Nissen, and his or her colleague. So in this, for your interest, you can click this link, okay? If you just look at it, it shows us what? as we have all learned about the association of measure, it showed us, they look at this, first of all, this is a systematic review. This is a meta-analysis, which we mentioned is the highest tier of evidence, remember? Okay. In this systematic review or meta-analysis, they have evaluated multiple trial studies looking at this drug and the risk of cardiovascular related events. What they found is they have included 42 clinical trials. Can you imagine? They have included 42 individual RCTs and then analyzed 27,874 patients. They look at two outcomes, myocardial infarction and cardiovascular death. What they found, can anyone help me interpret the results? We have odds ratio here. Does that mean from these findings, the risk of MI associated with this rosiglitazone is higher than the comparator? It is higher, right? The odds ratio does not include 1, right? The odds ratio, specifically, there are 43% increased risk as based on the findings, right? What about the cardiovascular mortality? Do we have, based on the finding, do we observe an increased risk of CV deaths associated with this drug? Some of you are nodding your head. Well, I'm sorry. Yes, if you look at the point estimate, it is yes, but the confidence interval is a little tricky. It includes 1. So we can say that it's numerically increased risk, but it's not, there's no statistical significant association with the drug regarding the CV deaths as compared to comparative. But so you as a pharmacist, I actually watched a video about this drug. FDA has hosted 2 days workshop, including inviting medical professionals and physicians, many famous physicians and investigators to talk about the drug. So you, as a pharmacist, if you were invited into the conference with other FDA regulatory bodies and other, clinicians, with this data, which you just read, and from the New English Journal of Medicine, tell me your thoughts. Tell me your thoughts. I don't have poll everywhere that I can see everybody's results, but just tell me your thoughts. You can discuss quickly with your neighbor, A, B, or C. And if you don't mind, how many choose A? I mean, there's no correct or wrong answer, but we can have some conclusions following is share me your votes. How many of you voted A? Can you raise your hand? Okay, there are like less than 10. How many voted B? It seems several more. How many voted C? Oh, okay, there are also students voting C. Okay, so it seems to me, if I'm hosting this kind of meetings, if there is a kind of, different opinions, but it seems to me a balanced A and B, and I think more people voted B, maybe, I don't know. Let me move on, okay, and let me know if you change your mind, okay? So you know what happened? So after this meta-analysis, which I just showed you, this led to significant, because median report, this is a NJME article, right? On this famous drug. So this median report led to a significant drop in the sales of this drug. A huge drop in the sales. This drug, the sales of this drug dropped by 290 million. I forgot to put a number there. It should be a million or billion, maybe, but it's a lot, okay? I'm sorry, I just forgot to put a number. It's definitely not $290. It's either a million or billion. in the US just in the months following the release of this media report about the potential risk of this drug. Because as we have seen, MI, there is obviously significant increase. Although the CV, this odds ratio covers 1, but the range of the confidence interval is kind of wide. And the direction it pointed to, it is increased risk. So if I can interpret that results for the point estimate is 64% increase in a very severe outcome is a death, right? A cardiovascular related death is a strong outcome numerically. So for those voted A, good for you. I mean, the public also feel the same. I mean, this significant drop in the sales of this drug. And at the same time, subsequently, additional evidence from different sources. Okay, we have learned about different types of study design from the sources of another comprehensive meta-analysis by another team of authors, Manussi and Monami. It's another comprehensive meta-analysis. They, although they ruled out their additional risk of MI or CV deaths in certain patients, but they did find increased risk for hospitalization for cardiac failure. It's kind of mild. I mean, I wouldn't say mild. I mean, compared to death, mortality, hospitalization is mild adverse events. And another trial record also found increased risk of heart failure. And observational study evidence that focus on the real world patients, the nested case control study you all have learned, right? They found increased risk of CHF, coronary heart failure, acute myocardial infarction, and death associated with this drug. So what is the conclusion here? What is the decision making for the FDA? All this evidence, additional evidence of recent studies from either is a systematic review or is another clinical trial or observational studies, they led FDA to, they did not withdraw this drug, but they changed the label of this drug. If you read them more specifically from either one of these additional information, especially this meta-analysis, like I said, we always want to read a meta-analysis first. The evidence from meta-analysis is the highest tier of evidence, remember? Okay. They mentioned some high-risk patients, for example, those obese patients, they already have underlying higher BMI. They are more likely to have these adverse events when they finish taking this medication as compared to those relatively normal BMI patients or those patients who already have underlying CV risk, right? If they have taken this drug, they are more likely to be associated with increased risk of CV events outcomes. So all this information has led FDA to change a label to maybe have this indication focus on a group of patients with relative low risk. So I would say for the active learning one, there's no right answer, but I just want to show with you how the cases went after all the evidence about the risk of this safety of this, raising the safety of this drug after the clinical trial. After you have learned about the case study of the rosiglitazone, additional evidence from the real world, from different type of studies that conducted after its clinical trial. And this led the regulatory body to make a decision making about the label associated with this drug. Can you please conclude, or in your own language, what you have learned that that can be the potential application of pharmacoepidemiological studies, right? That is not just the randomized control trial that approves this drug, but the additional evidence from the recent pharmacoepidemiologists that made FDA to change its label for this drug. So can you summarize in your language what are the potential uses of this kind of pharma-epi evidence? Does that make sense? Like the case control studies, the meta-analysis, this is obviously not RCT, right? This is not a prospective RCT, but the regulatory body recognize the findings from these studies and they make different decisions. So for that, you can chat with your neighbor quickly. We can have 1 or 2 minutes, share how you thought about it. I mean, 1 or 2 or 3. Oh, you can think about maybe beyond these cases. You as a pharmacist, if you read a drug label, but in your practice, a patient encounters some serious adverse events, or in your practice, you read some evidence published maybe in the New England Journal of Medicine about the adverse events of this drug. How maybe you can, just chat with the neighbor, the potential uses, okay? Once you finish, I'm gonna just silence myself for a minute. Your neighbor in the front, in the back, exchange your thoughts. And yeah, let me volunteer for I'm sorry, silence myself. Yeah, chat with your neighbor. I mean, you have a friend who's sitting next to you, okay? Okay, any volunteer? I like that. I like that idea. New box warnings. Yeah, I like that. Good answer, Lauren. Like in another words that I want to put what Lauren said, like help the regulatory body to make the decision making, right? Add box warning. What else? Can you be more specific, like what are stakeholder that you're trying to convey? Because in Lauren's case, the stakeholder is regulatory body, right? So what's the stakeholder here? Yeah, yeah. Okay, so you are saying this information may help the prescribers to choose alternative for the patients. Yeah, this is also great answer. This is like the evidence-based medicine or evidence-based prescribing to help the prescribers, to help the providers, or help you as a pharmacist, right? The pharmacist can be the stakeholder, great. Anything else? Anybody want to try or? Okay, anything to add? Okay, are we good? Okay. Okay, let me move on. So your peer covered most of them. Evidence-based medicine, which I like this adopts the best practice because our understanding of drug is also evolving. Like we have reiterated a lot in this class, especially in the study design. RCT has limitation from the first my class. RCT is a gold standard to understand drug efficacy, to build causality because randomization, but it has limitations, right? One major limitation is the small sample size. It cannot detect some safety events, which maybe takes years to occur, and also some real adverse events. And it also does not reflect what is real, what are the patients that you as a pharmacist see in the real world, okay, in your communities. Okay, the older patient that you have seen in your practice in the CVS, the older grandma can never get enrolled in the randomized control trials because of the underlying medical condition. So the pharmacoepidemiology research can help us to adopt the best practice for the evidence-based medicine. And secondly, as Lauren mentioned, it can maybe because our understanding from pharmacoepi about their drug safety, we may need to, from the FDA perspective as regulatory body, may add some box warning to these drugs. For one of the drugs that my research focused on, for rheumatoid arthritis patients, the orally taken Janus kinase inhibitor, right? It's a normal drug, which is just not orally taken. Can you imagine that? How good is that? It's targeted therapy is orally taken, but it was found to be associated with cardiovascular risk from additional clinical trial and also from some observational study. So this caused FDA to add a box warning to this drug, that this drug, Janus kinase inhibitor as oral drug for rheumatoid arthritis patient cannot be prescribed in patients who are elderly or who have baseline cardiovascular risk. This is the kind of box warning. Make sense? Okay. And in a pharmaceutical company, the marketing body, if you ever get a chance to work in a pharma, either in your epi rotation, or I don't know about the layout, but maybe through your internship, there are marketing bodies, there are medical affairs team in the in the pharmaceutical company. They will use the pharmacoepidemiology evidence, not only to make decisions that, how to say, because like Lauren said, there can be box warning. This is kind of decision, kind of, how to say, there are the decision, good decision. I'm not saying that bad decision, but that decision leads to kind of, what I want to say is that some of this evidence can also help to expand indication of the drugs, okay? If you have a drug that is marketed for certain conditions, based on the pharmacoepi research evidence, there are off-label use of this drug, and patients have shown the maybe relapse or remission based on off-label use. This can expand the labels of this drug, expand indication of this drug. Does that make sense? Okay. And this is what pharma really wants, okay? Without undergoing another separate trial, they can expand their indication of this particular drug. And I don't have a data on my hand, but more and more in recent years, FDA has released the guidelines that they are willing to use such post-marketing pharmacoepi evidence, or called real-world evidence, to approve another indication, maybe for a drug that already approved for a certain indications. Okay, and the legal bodies can use the causality of the negative outcomes for some legal issues. Okay. Those are the different aspects in terms of different stakeholders that can leverage the evidence from pharmacoepidemiology studies. Any question? Okay, let me move on. Now, another fun part about today's lecture is the checklist. Okay, it's the checklist. The checklist is kind of lengthy, but all the information, most of the information you have already learned. Okay, this is almost the end of the module 2. So you have already have that knowledge. Either is a statistical analysis, or is the study design, or is the medication exposure, or the outcome interest. You have already have that foundation in your module 1 and module 2. Okay, but I will emphasize of some new things that we are gonna see in the following slides. In the checklist, there are 3 big portions, okay? One is the research question, study design, and population. B is the data analysis, is what you have learned in module 1. C is the results interpretation of study findings. So I'm gonna quickly show you how does this checklist look like. And have you all have access to that Gravy Excel sheet that I posted? Okay, great. Okay, great. And if you all can do me a quick favor, I believe in that Excel sheet, I have included all the items in that Excel sheet. No? Oh, yes. It should be there. Okay, great. At least Emily has said yes. Okay, so if you have question, you can ask Emily, both the Dr. Gravy as our TA Emily, another Emily here, okay? Okay, you see that Excel sheet? Okay, great. Are 10 questions in the part A, and 2 questions in part B, and 6 questions in part C. Okay, it's not that long. Let me go through them. Now, I would generally share with you that in the, if I can draw you a little attention here, okay? In the part A, 10 questions, most of them either is from introduction or from methodology. And part B, data analysis, they should be from methodology. C, results interpretation. Well, they are from the results or from the discussion. So as you all know, for a manuscript, there is a abstract, introduction, method, result, discussion, okay? Now, I want to really focus on some important things here. Part A, in the research question, study design population. So if you don't mind, you all also can, have that article at your hand or something. By the way, the task is not due today because I thought it's the spring break. Really, everybody is trying to go back home. I don't want to have you done tonight. I mean, it will be very not good. I mean, I know everybody is trying to have some fun today, or in the coming spring break. So the task is due next Sunday. Is that okay?
Are you talking about the doc that everyone is supposed to be able to open?
That one, I don't think we have time, but
You can't open it.
you cannot open it? Oh, that's good. I mean, we don't need to, that's fine. But there is an Excel sheet which shows you the checklist, right? Okay, are we all good here? Okay, because you also gonna later teach those who are not here, okay? You guys here are not just for you. You also gonna teach those who are not here. Okay, everybody? You have that Excel sheet, right? So let me quickly reiterate. That task is due next Sunday, 11:59. You can email me or email Dr. Gravy, okay, electronically. I know you guys like digital submission. And you're gonna work with your group mates. And the group, yes, same group as the fun task. You already have that connection relationship with the same group members, okay? Is that okay? I really think it's better for you to work with your group mates. I know there are several items. Okay, are we clear about the submission date and who you're going to work with? And we have the Excel sheet to just submit Excel sheet. And please remember in the Excel sheet, put your group number and your group mate's name there, okay? Yeah, just put your group member, group mate's name there. And if you, as a group, yes, turn in as a group. You can, one person, you can email me or email Dr. Gravy. I have already chatted with her. And if you also, you can CC your group mates, but it's not required. But it's better for you to put their names there. I know who is in your group mate as a group, but put their name there just to showing everybody's participating, okay? Does that make sense? You all know your group mates, please. Yes.
So. Yes. Set. Checklist.
Because we don't have time, I'm sorry. Yes, I'm gonna delete that. Yes. So we just, yes, we need to do the whole thing. We need to do the whole thing. That makes sense. And it's due next Sunday. I'm here to help you, okay? I'm here to help you. Now, let me quickly move on. I'm here to help you. I will stay after class if you have any more questions, but I really need to take time to talk about something important here. So in the part A, as we observe, there are 10 questions. The first three questions are very straightforward. In the introduction, the researcher must identify why this research is important. Okay, what are the current gap in terms of understanding of this research? Okay, and study objectives are usually at the end of introduction, and researchers may state a hypothesis at the end of introduction as well. Here, question 4 to 7 are something that I want to highlight here. In the medication exposure, question 4 is about medication exposure. What is medication exposure? Obviously, it's about a drug, but something you all know as a pharmacist. The drug have different formulations. The drug have different strengths, okay? So when we talk about exposure of interest, it can be drug A versus drug B, okay? It also can be drug of different strength. It can be high dosing versus intermediate dosing versus no dosing. I'm sorry, low dosing. I'm so sorry, low dosing, okay? Because as I mentioned, drug has formulation, has strength, which all influence the effects of the drug on the outcomes. So then next question is, what is the outcome interest? The outcome interest, as you all learn, is the endpoint. It is the, can be incidence or prevalence of disease, okay? It can also be in our prior case study, mortality, hospitalization. It can also be some medication utilization patterns we have all learned, adherence, persistence, okay? This all can be the outcome of interest. And in terms of study design, remember what types of study design we have learned? Major ones.
Case control study.
Beautiful, yes. Case control study, cohort study, beautiful. Those are the observational studies. And we have also learned about RCT, clinical trials, we call it experimental studies, okay? Oh, of course, we have learned a quasi-experimental study. Lastly, the source of study population. When we talk about that, I want you to be specific about where is the setting of this study? Is the study conducted in the US population, or is the study conducted, in a European population, or like maybe the study is just conducted in a single hospital versus a study is conducted, across different states at a national sample level. It's about the setting, it's about the location, it's also about the sample size, okay? Like how many patients that are evaluated in this study. It's also about the sample size. So I use this graph that I created based on the Dr. Dienstrom's book about pharmacoepi research I created based on her book to help you have better understanding of those terms. Any question here? Okay. I believe it should be very straightforward or very simple, digestible for many of you already. Okay. Moving on. Question 8 to 10. It's something maybe new to you today. I draw your attention, really want to draw your attention here, and it should be included in your exams, and I promise you it will. Okay, it's not hard, okay, maybe something new to you, okay. One is bias. There are two bias we are talking about here. Selection bias, information bias. Remember, these two bias, it's an arrow. Those are all two bias are arrow, and I'm gonna quickly explain what does that mean. Those two bias are arrow. And there's also another term called confounding. Let me start with the selection bias. The selection bias is that an arrow that occurs between maybe the exposed group and unexposed group in terms of there's a systematic difference of some baseline characteristics between these two groups. I'll give you one simple example. If in a cohort study, researchers wanted to evaluate incidence of outcomes between group A versus group B, right? This is a cohort study. But one group of patients, but they because of this cohort study, so some patients may lose to follow-up. In group A, there are many more people lose to follow-up as compared to group B. It turns out the group A and group B have systematic difference. This is called selection bias. Okay, and selection bias is more common in the case control studies. The cases and the controls may have systematic difference in terms of some baseline characteristics. It's called selection bias. Another term is called information bias. Information bias means that there is an error in the classification of exposure versus control, or maybe in the misclassification of disease or undiseased outcomes. And information bias is also very common in case control study. Why? Because case control study, their exposure of interest. I will give you one simple example. I think maybe we talked about this already, but remember in a case control study, we start with cases and controls. For example, if we wanted to look at exposure of a drug, maybe drug A, whether may lead to a higher risk of birth defect among the pregnant women. Okay, it's a valid question, right? We have a group of cases, a group of women who have the birth defect child versus another group of women who do not have. And like we said, those with birth defect child group of cases are more likely to remember what is happening, whether they have taken a drug A versus drug or not taking a drug A. Okay, but the other group, they may forget, although they have taken drug A, but they may forget what happened before that, before the event day, because they are healthy patients. With that, there is a distorted information of the exposure for the cases and the controls. It leads to information bias. There may be misclassification of exposure drug A. We may underestimate the extent of drug A used among the case and control. Does that make sense? I know it's not a perfect example, but anyone can understand the misclassification bias or information bias. It's about the error that we made when we classify them either as a exposure or as a unexposure. Another term is called confounding. Confounding is it means that a third variable that influence both the grouping of the exposure and outcomes, we call it independent variable, as well as also influence the clinical outcomes. Okay, two groups of people that we are evaluating for the survival outcome. I mean, all of them are cancer patients. We are evaluating either the drug A versus drug B, which drug has better survival outcome, can allow patients to live longer. The drug A group may be all the, like if we want to compare the immunotherapy versus standard chemotherapy in terms of which one treats the better patients among a group of breast cancer patients. We found out that chemotherapy group patients has a better survival outcome. But, you know, immunotherapy is very expensive. They may be just treated with the patients who are at a stage 3 or stage 4 cancer patients, right? And the stage of cancer is definitely a significant factor influencing their survival. So this, their disease severity, their cancer stage is called confounding factors. It's a third variable that not only influence whether they are assigned to immunotherapy or the chemotherapy, but also influence their clinical outcome, survival outcome. Question here. I know I talked a lot here. I had a lot of talking here. I would really like to hear from you if you have any additional comments that you think I should add or you want me to hear about either one of the bias or the confounding concept. Any comment, question are welcome. Oh, please, yes.
These tests, do you want us to with all the questions that are in the checklist? Is that?
Absolutely no. No, I did not remember myself. No. Yes, you need to digest the terms. Absolutely, Sarah. You need to digest terms. It may give you an example. Hey, I'm giving you an example, like the cancer example I'm giving you. What are the problems here? Okay, we found out that the chemotherapy patient has a longer survival than the immunotherapy group. Does the immunotherapy is not that effective as the chemotherapy? Why is the problem? So let me ask you this kind of question. What kind of, issues here, right? Okay, the terms are very important. Yeah, valid question. Any comments about those terms here? Okay, or should I move on? Okay, you will understand better once you have more, work with more example questions. And now let me quickly move on. This is the example that I'm talking about. The study found out patients who received the drug appears to have worsened outcomes because we are looking at a new chemotherapy as compared to maybe the existing ones. The pharma company. So what are the issues here? Anyone want to try? It is confounding, yes. Yes. Can you be more specific? Yes, you are getting close, yes. Absolutely. You are in the right direction, yes. Yes. Yeah, maybe, yes, as Sarah mentioned, yes, that's definitely about severity. The chemotherapy, can you be more specific, Sarah? Yes, you are in the right direction, yes.
Like, specific about, like, it would, like, the worst, I'm sorry. Like, the higher the stage they were given,
yeah,
the less chance of survival.
That's correct, that's correct. So let me ask you another question. Do you think with this result, the new chemotherapy, so there are two drugs, right? New chemotherapy group and older drug, which group may have higher severity, baseline severity. So you are in the right direction. So we have two drugs. One is the new chemotherapy. We want to test whether it's better, right? We have existing standard of care, okay? Maybe a radiation, maybe we have existing standard of care. I'm not an expert on oncology, but we have two drugs. The researchers, the pharma wanted to test this drug is better than that. This drug, the patient with this drug has longer survival. But they found out patient with this drug, this new drug, has lower survival. What do you think may be the problem? So maybe, yeah. Oh, whoever. So this drug, yes, Sarah is right. Absolutely, they have different stages. So this group of patients may already have higher baseline. They may be, let me be more extreme. This group of patients may have maybe all stage 4 cancer, but this older drug may be just treated with patient maybe stage 1, stage 2. Okay, this is called confounding by severity, because we know immunotherapy, they are used for the patients who are at almost stage 4. They are very, very effective. Some patients even get cured, get remissions. They are used for those with higher underlying disease severity. So what you should do, this is the explanation. Does that make sense to everyone? Okay, you want to compare two drugs, but the two drugs are treated with patients with different baseline characteristics. If not talking about cancer, I can talk about rheumatoid arthritis. The oral medication, they are usually treated for the patients who did not respond well to biologics. Patients at a very higher severe rheumatoid arthritis or high disease activity. So if we want to compare the oral drug with the existing biologics, which has been in the market for 20 years, these newer oral drugs, the patients are more severe patients. We cannot just compare them. We will find out the newer drug may not be good as the biologic treated group. Okay, that's the confounding by disease severity. And Sarah gave us good answers. They mentioned maybe the severity issue, and with cancer patient is stages of cancer. So let me move on. And what are the ways to control confounding? The same question. I know we don't have time, so let me just move to the result. There are different ways. One way is to use multivariable logistic regression, multivariable linear regression. We're gonna use a variable with the data. The data may have a variable, stage of cancer. We're gonna control that variable, include it in your model. Okay, we're gonna include it in your model. It's called multivariable regression. If it is look at survival, what kind of multivariable regression we're gonna use? Multivariable Cox. Remember, yes, multivariable Cox regression. Yes, beautiful, Emily. Okay, but if we just look at yes or no, what is that called? Multivariable linear is continuous. What is binary? Beautiful, yes, multivariable logistic regression, beautiful, okay. Okay, we can also use stratification. We can stratify patient based on stage of cancer. Okay, all this group is stage 1, all this group is stage 2, all this group is stage 3, okay? Then we don't have that problem, okay? Does that make sense? The subgroup, that's also another method. Another method, third method is called matching, okay? Two groups, but in the group 1, they are 10% stage 1, 20% stage 2, same with group 2. We're gonna match them, okay? They're gonna have equal balance in terms of disease severity. This is called matching. Two groups are similar in terms of baseline. Okay, moving on. Lastly is the results interpretation of findings. This is very straightforward, but there's just one thing I want to mention. It's the generalizability issue. This is called internal validity. How much your results can be applied to another setting, another group of people. So this is the activity assignment, or it is, you are gonna work with the same people you're working with for your fun task, and it's due next Sunday. And you're gonna look at this article. It's by Anderson. which is available here, it is available in the black box, blackboard, and the submit is next Sunday. It's here, okay? The task. I know the class is over. Any question for me? The article is here. Everything is here. Are you gonna use this Excel sheet? Oh, yes. Sorry? We have quiz. Quiz has already released, right?
But we could change the 17th instead of this Monday.
It is next Sunday. Yeah, I'm sorry. Oh, wait. Oh, sorry. There are two questions, Lori. I'm coming back, Lori, for that. And Shabby, I'm coming back. There are two questions. Oh, you mean the quiz? You both are talking about quiz, right? Okay, the quiz is available, right? The quiz is not available?
Do the 10.
Oh, it is open at 5. Yes, it's open at 5. Yes.
16th, 17th.
10 today?
It's like March 10th. It's this Monday.
Next Monday, right? Still next Monday, right? We have to move. Oh, okay. I see what you're going. You want to move the week after next week. Okay. You think next Monday is a little challenge? Okay.
So we can.
Okay, I will make that. March 17th, right? March 17th, right? Okay. Do we need to for this about March 17th, or you are okay with Sunday? Okay, I will do that. Yes. I understand. The Monday after next Monday. Have a nice break. Safe travels. Okay, clear. Please teach those who are not here, okay? Let them know.
Study that learning, leave it here and then do it.
You started pretty slowly. It's a good.